Dr. Chi, a question for you regarding your crossover study and the quality of life of that. Do you think that the prednisone had a lot to do with the quality of life issues and the difference between the two arms?
I'm just going to repeat the question for the webinar. So the question was, does prednisone have any effect on the quality of life differences between abiraterone and enzalutamide? It's an intriguing question, and I don't know because we don't have sort of abiraterone without prednisone versus enzalutamide, so I just don't know. I have tried adding prednisone to patients on enzalutamide. I don't think it makes that much of a difference, but that's anecdotal. I think, to be honest, what some of the difference may be from is age. There's a difference in the age between the two populations, and as a further analysis that I did not show, the older patients seem to be affected more with the fatigue. And that might help with their decision-making about which treatment to give which patient.
So this is obviously being, and I'll be presenting some stuff this afternoon, but the fatigue issue and the rest with enzalutamide, the more I look at it, the more I think the dose might be different, or the PK levels are different in different patients, and I actually see more benefit in reducing the dose than adding another drug to combat the fatigue issue. So I think some of the elderly patients might be metabolizing it differently, but clearly there's something going on, and we're giving the same dose regardless of size, weight, hepatic function, and I think some people really the dose is probably too high, and surprisingly when I lower the dose, the efficacy seems to be maintained.
Any other questions?
I think Christina.
Christina?
Sorry, I don't know if I missed a piece of that, but what about the prednisone dosing, like 5 versus 10? Or even at the latitude study, I think they used 5 milligrams prednisone, and then we looked at the kind of post with the capture group and studying 10 milligrams of prednisone. So those studies that didn't get away with only 5 milligrams.
Okay, so that's an excellent point. So it was 5 milligrams that was used in both studies, with the idea that they were likely going to be exposed to longer time on prednisone and to see, and in fact there was more hypokalemia with the 5 milligrams. So I think you could get away with 5 milligrams. You just have to be cautious that these patients need to be followed, and at least in the latitude they started with 5, and clearly if they had issues they were supposed to go up to 10. But when you look at the hypokalemia risks, they are higher with the 5 milligrams. Kim was the senior author, so he has other comments.
It's hard to know if there was increased hypokalemia, and there was increased sort of mineralocorticoid side effects if you try to cross the study compared to 301 or 302. But you also have to remember these patients were on treatment for a lot longer. Median duration of treatment was 2 years, so you have a greater chance of having a side effect within that time. Personally, I kind of moved to 5 milligrams with prednisone, but I think you need to monitor, and especially in that first few months, and be careful about the incidence of hypokalemia. At ASCO, there was also a poster looking at abiraterone without prednisone, and a lot of patients were fine without having to have prednisone added or their mineralocorticoid side effects managed.
It's interesting, at ASCO there, Demona was saying that 5 milligrams is pretty much all you need, and in fact you probably don't even need it.
In many patients.
Yeah. Any other questions? I'm just going to read a question from the WebEx, and they pertain to the efficacy results of both Charted and Latitude. And the question is relative to these one: do you really think the real-world experience will match those found clinically? And so I guess what they're thinking is that maybe the clinical data is too good to be true.
Thanks, Kim. I think we all live this when we do clinical trials and the real world. And I think in the real world, we get patients that are more beat up because, in clinical trials, you have to be at a certain level to be eligible. There's a certain motivation. But I would say, the results in the real world are pretty similar to what we're seeing in the but obviously, sometimes we're pushing the limit in the real world, where even a patient is anemic, we won't just give up on him. So I think if you look at what kind of patients are being treated, we are getting the same results if we're putting the same kind of patients in the real world.
Do either of you see long-term responses in those treated patients?
I have a few patients that are in complete response for over 10 years.
And that's what people are saying, that you don't get that with these ARTs, is this plateauing of a few patients may respond long.
We have seen them too. I mean, we still have patients on 302 and Prevail that are still stable, and the studies have been closed for years.
Yeah, I still have a patient that was on a firm, and so that he's still getting enzalutamide now. And how many years ago was that? I don't know. But obviously, whenever you take a clinical trial results and you put it into a population, you don't get as good outcomes because you weeded out all the patients. You're including all the patients that you normally wouldn't have gone onto the clinical trial. Our abiraterone enzalutamide sequencing trial is really a population-based study. If you could get Abby or Enza, you were allowed to go on that study. And we had very open criteria. And you can see that the time to progression, the time to PSA progression, was much shorter than what you saw on the randomized trials of Kruger 302 and Prevail. So you do see a blunting of the effect.
Are there any questions? Questions on interwebs? My question to Kim is regarding gene panels and ARV testing. You know, there are an abundance of prognosticating gene panels, and now both Johns Hopkins and Epic platform for ARV7 liquid biopsy. Are these valuable? Are you using them? And is your sequencing available for anyone here to access?
So I'll address the ARV7 first. I was down in South America giving a talk, and down there the medical oncologists are actually sending blood samples up to Johns Hopkins, and they're providing the test and giving them a result, and they're basing their treatment based on that. And I cautioned them not to do that because it wasn't a validated test. And indeed, at ASCO, there was a presentation looking at galeterone versus enzalutamide in patients that were ARV7 by this test. And the response rate for enzalutamide in ARV7 positive patients was roughly 50%, which is what you would expect anyhow. These were very poor prognosis patients. So it basically kills that test. It shows that patients actually do respond even if they have ARV7 positive. So I think that you have to be very cautious about these biomarker studies that are coming out that are, have shown remarkable results in small numbers of patients.
And they're all retrospective.
And they're retrospective. So I think we need to be very careful about how we interpret those things, and this is a good example. In terms of our gene panel, this is something that we're doing across BC. So any patient that was CRPC that's going on to treatment will get the gene panel done as a research study. More importantly, I think it's the germline data. Now that we understand that about 10% of patients have germline hereditary DNA repair alterations, this is, unexpected. We've only learned this in this last year. We used to think it was 1% of patients. Now we know it's 10% with those with lethal disease. And I think we really need to find these patients for treatment as well as for their families, right? So these are the patients most at risk. These are patients you probably wouldn't want to put on surveillance, for example, if they did have a hereditary cancer, because they seem to be more aggressive. So that's where I think we should be thinking more along the hereditary lines across Canada.
Any questions? I know a question that I'm going to ask on behalf of the urologist, and this came up yesterday at a meeting in which there was an attendee that had stated that if it was for free, with the data that was shown, and again, we're looking at the PFS, FFS data from Stampede, and based on the conclusions of the author who said that it is applicable in all patients undergoing adjuvant deprivation, that he would start abiraterone in every single patient the next time he starts someone on adjuvant deprivation. And this is coming from a urologist, correct? Just your thoughts on moving treatment in the general population. Just your thoughts, 2 cents, because I know that it may be used in that sense just because of the conclusions, these strong and fast conclusions.
Right, I think you have to be cautious that the authors of that study are talking about their patient population. And I remind you, those are really high risk, even though they were non-metastatic, those are patients with PSAs over 40, T3, T4 disease, Gleason 8 to 10, that are starting lifelong ADT. So you've taken that decision. And even there, I would be cautious because some of those patients do really well on ADT. I think it's premature today to say we would be using it in the non-metastatic setting. I think where there's clarity is in the metastatic setting. This is something hopefully will be approved quickly. We're not all as lucky as in British Columbia, where we can go and get access to something that's not Health Canada approved. But I think, you know, us as a community and the patients are obviously looking for more options. Whether one is better than the other is a moot point. I think we need options because we have a variety of patients that come into the clinic, some that can get easily chemotherapy and tolerate it well, others that don't. And so we really need to have options, and this should be an option as quickly as possible.
Kim?
I agree with all of that.
So you would not identify a single M0 patient that you may consider this in? Just to challenge you. Like for example, that Stampede patient who is a higher risk.
Look, I mean, you know, having said what I said, we are getting chemotherapy to very high risk young patients in combination with radiation, but it's a finite 6 cycles. The issue is if we start it, when do we stop? And a patient can live 10, 15 years with even the highest risk localized disease, and that is going to be the issue. You know, Kim was talking about the 2-year exposure.
Yeah, I agree. I think we have to be very careful because any drug can have long-term side effects that we're just not aware of, and until that data is more mature, I would not do it.
Okay, great. Any last questions? Well, it's 7:30, and I just want to thank the speakers, the audience, and again, thank you for joining us this morning for the symposium. 2 things. If you could please fill out your evaluations, and as well, the WebEx will be available for you to look at in 2 days online. Thank you very much.